Welcome to The Explainer. Today, we're going to build a really practical framework for managing migraine. This is for all you busy medical trainees out there who need clear, actionable info for your next clinic day or, let's be real, your next shift in the ED.
All right, let's jump right in. Because when a patient comes to you with a headache, your first job, it's not actually to figure out if it's a migraine. Your first job is to make sure you're not missing a complete disaster. Seriously, that initial assessment, it is everything.
So, here's our game plan. We're going to walk through this just like a real clinical encounter. We'll start broad, looking for those scary red flags, and then we'll start to narrow it down, figuring out the difference between common headaches. And finally, we'll get laser-focused on mastering the diagnosis and treatment of migraine itself.
Okay, so first things first. Before we even think about migraine, we have to be on high alert for signs of something much more dangerous, some underlying cause. This is what we call a secondary headache.
And this is really the crucial question, right? When is a headache a 911 call? What are those specific things in a patient's story that should immediately set off alarm bells in your head and make you think, maybe this isn't just a simple headache?
You've really got to think of these red flags as major forks in the road. Any single one of these completely changes your diagnostic path. These aren't just minor details. They are giant flashing signposts that scream for a totally different workup. And that usually means getting imaging, like right now.
And I want to be crystal clear about this thunderclap headache. We're not just talking about a really bad headache. This is a headache that goes from 0 to 100, its absolute peak intensity in under a minute. If you hear that story, it's a medical emergency. That patient needs a non-contrast head CT immediately to rule out something like a subarachnoid hemorrhage.
Okay, so you've done your due diligence, you've ruled out all the scary stuff. Now, and only now, can you confidently turn your attention to the primary headache disorders. These are way more common, but being able to tell them apart is absolutely key to getting the treatment right.
This table does a great job of laying out the key differences. Look at the patterns here. You've got your tension type, which is that classic band-like pressure on both sides. Then this cluster headache, super severe, short-lived, and it comes with these weird autonomic signs like a watery eye or a runny nose, but only on one side. But then you look at migraine, and what really sets it apart are those associated symptoms, the nausea, the sensitivity to light and sound. Those are things you just don't see in a typical tension headache.
So building on that, let's really zero in on migraine. This thing is incredibly common, but you'd be shocked at how often it's misdiagnosed. How many times have you heard someone say they have a sinus headache? A lot of the time, that's actually a migraine, and it's a shame because we have really clear criteria to diagnose it correctly.
Okay, so when you're in the room with a patient, taking their history, the Pound mnemonic is just a fantastic, super high-yield tool for screening. Seriously, if your patient checks off 4 or 5 of these boxes, the chance that they have migraine is really high. It's just a quick and dirty tool that's great to have in your back pocket.
Now, Pound is a great way to start. It's a great screening tool. But for a formal diagnosis, you have to turn to the official stuff, the ICHD-3 criteria you see right here. And I want you to pay close attention to parts C and D. The pain isn't just a bad headache. It has to have at least 2 of those specific qualities. And those associated symptoms, the nausea, the photophobia, those are basically non-negotiables for the diagnosis.
Okay, let's talk about aura. About 20 to 30% of patients get them. Those temporary visual things like flashing lights or sensory symptoms. And this is a critical counseling point. The presence of an aura, any aura, is an independent risk factor for stroke. And because of that, it directly impacts contraceptive choices. The bottom line, estrogen-containing contraceptives are a no-go for these patients.
All right, so we know how to diagnose it. Now, how do we stop an attack in its tracks? The goal for acute treatment is super clear. We want to get the patient from miserable to pain-free and totally functional again. And we want to do it fast, ideally within 2 hours of them taking their medication.
Your approach here has to be stratified. You have to match the treatment to the severity of the attack. One of the biggest mistakes you can make is forcing a patient with a severe, disabling migraine to fail a simple NSAID first. That's just cruel. For a mild to moderate attack, sure, an NSAID is a great place to start, but for anything moderate to severe, you need to go straight to a migraine-specific therapy, like a triptan.
This right here is a really key comparison in modern migraine care. Triptans have been a mainstay for years, but they work in part by constricting blood vessels. That's why they are an absolute contraindication for anyone with a history of stroke, heart attack, or really any significant vascular disease. But now we have Japans.
They work on a totally different pathway, blocking CGRP, and they do it without that vasoconstriction. I'm not exaggerating when I say these have been a complete game changer for so many patients who couldn't take triptans. Now, this is so important. You need to understand that avoiding medications like opioids or butalbital isn't just about the risk of dependence, though that's a big deal too. The real kicker is that using these drugs can actually make the migraine disease worse. They significantly increase the risk that a patient's migraines will transform from being episodic to being chronic. And trust me, chronic migraine is a whole different beast. It's way more disabling and so much harder to treat.
Okay, let's switch gears and talk about prevention. Because treating attacks when they happen is important, of course. But for people who get migraines frequently, the real key to giving them their life back, to improving their quality of life and reducing their disability, is to get proactive with a prevention strategy.
This is a question that comes up all the time in clinic. When do you pull the trigger on starting a daily preventative medication? What's the threshold? How many headache days a month is too many?
Well, the evidence actually gives us a pretty clear number to work with: 4. Once a patient is hitting 4 or more headache days a month, it is absolutely time to sit down and have a serious talk about starting preventative therapy. And by the time they get up to 10 days a month, it's pretty much always the right call.
But wait, before you even think about reaching for that prescription pad, please don't skip this step. These lifestyle modifications, they are the absolute foundation of any good prevention plan. I'm talking about things like consistent sleep, regular meals, staying hydrated, getting some exercise. These things can have a massive impact, and they need to be part of the conversation you have with every single one of your patients.
All right, so when lifestyle stuff isn't cutting it, these are your heavy hitters. These are the top-tier, level A evidence-backed oral medications. These are your first-line choices. And the art of this is choosing the right one based on the patient in front of you, their comorbidities. For instance, if a patient is also trying to lose weight, topiramate might be a great 2-for-1. Or if they have high blood pressure, a beta blocker could be the perfect fit. Okay, so to wrap all this up, let's just boil it down to a few super high-yield pearls. These are the key takeaways I want you to remember for your next shift. Pearl number 1. Trust your clinical judgment. If you have a patient with a long history of the exact same headache, it fits the migraine criteria perfectly, and their neuroexam is totally normal, you do not need to scan them. You can be confident in your diagnosis.
Number 2, treat early, and you need to hammer this point home with your patients. The single biggest reason acute treatments fail is because people wait too long. They wait until the pain is a 10 out of 10. You have to tell them to take their medication the moment they feel it coming on, when the pain is still mild. That's when the medicine has the best shot at working.
And finally, pearl number 3. This is your critical safety check. Triptans are one of our best tools, but before you write that script, you must ask about any history of heart disease, stroke, or uncontrolled hypertension. It's one simple question that can prevent a really serious problem. So, which preventative strategy, the lifestyle changes, or the medications are you going to talk about with your next patient? That question really leaves us with a final thought. Because at the end of the day, great migraine care is a partnership. It's a team effort between you and your patient. And that partnership really starts with the conversation you have about building a comprehensive prevention plan, one that uses everything we've got, both lifestyle and medicine.